Cast is now starting. All attendees are in listen-only mode.
Good evening, everyone. We only have a minute until 7 o'clock until we go live with our panel, but I just wanted to do a quick sound check just to make sure that we are transmitting. So if you do hear me, can you please type yes into your questions box? Perfect.
Yeses.
Thank you. Okay, so I will get started now that it is 7 o'clock. Firstly, good evening, and thank you all for joining us for this New South Wales COVID-19 update webinar. I am joined tonight by our panel, Dr. Charlotte Hespy, Dr. Penny Burns from RACGP, and from the New South Wales Ministry of Health, we have Kerry Chant and Nigel Lyons. So thank you all for joining us this evening. Before we get started, I will just do an acknowledgement of country. So we do, sorry, 2 seconds, I've just had some technical difficulties. Oh my goodness. Sorry, guys. So I'd first like to do an acknowledgement of country. We recognise the traditional custodians of the land and sea on which we live and work. We pay our respects to elders past and present. So thank you for that. I will pass you over to Dr. Kerry Chant for a New South Wales COVID-19 update.
So I'll give you the update that was provided this morning, and many of you will have seen that. We had 2 additional cases overnight, and both of those cases were not community acquired with no link. So one of them was in a person who'd returned from overseas who was in quarantine in a hotel, and the other one was a contact of a confirmed case. We have gradually seen a stabilisation of cases. So we've been getting small numbers of cases, some in the returning overseas travellers, some associated with some notable clusters, particularly in some aged care facilities, and a small number of community-acquired cases where it isn't clear the source. Our strategy has been very much to increase testing so that we can identify the scale and scope of community transmission. And so hence there would have been information sent out to GPs about having a very low threshold for testing. Anyone basically with any respiratory symptoms or unexplained fever, we're suggesting have a COVID test. And we have got plenty of lab capacity. And so we have got in excess of a capacity to test over 8,000 specimens a day. And we really want to get that push to really flush out any transmission chains in the community. So thank you very much for all your contribution to that, and it is important. One of the things that we're also considering now is what are the strategies, what does a normal look like in COVID? So what are the level of restrictions we need to maintain the levels of COVID in the community suppressed to very, very low levels. And obviously we've got schools going back, but the Premier has indicated that National Cabinet and those National Cabinet processes are considering what restrictions could potentially be loosened. Just as an important point, it actually takes at least 2 weeks before any change is reflected in the data, because we need a few incubation cycles to actually see any upswing in cases. But having that high rate of testing, and particularly making sure that's equally distributed across regional, rural areas as well as metropolitan, and also that we're reaching vulnerable groups, that gives us assurance that we're not missing significant community transmission. And our ability to contain COVID is only going to be as strong as our ability to reach the most vulnerable in our community. And I think that's where the Australian healthcare system with Medicare is so pivotally important at encompassing access. But we're still going to have to work with our homeless services, our drug and alcohol services, and our other settings where people may perceive barriers to engaging in care, where we need to have sort of more outreach services to sustain high levels. And I suppose as an example is Singapore was, I think, lauded very early on, but they've run into a few challenges now when it's actually got into their migrant workforce, into those sort of more factory-based and dormitory-style accommodation. So it's a salient lesson as we go through this. We really need to make sure that we have a very statewide perspective, but also perspective that our testing reaches the most vulnerable. Thanks, Charlotte. That's probably a summary of where we are at the moment.
Thanks, Kerry. Nigel, is there anything you'd like to add to that sort of summary of what's been going on?
Yeah, I think on the service side, Charlotte, the issue here now is that we, I think, had a very quick and swift response around ensuring that we had capacity freed up in our services to be able to respond to COVID, whether that was in emergency departments, acute hospital beds, or intensive care units. And what we have seen with the success of the public health measures that Kerry has outlined and the response by government and the community to the call to, take on these social distancing measures and comply with what's been required to reduce the rate of spread of COVID-19, we've actually got a lot of capacity in our system now. So we've got hospitals that have seen big drops in emergency department activity, and that's not just in the less urgent categories, it's across all categories. We've had less admissions to our acute wards. We've got capacity in our intensive care units. And the issue there is that we're worried that people aren't accessing care when they need it, either out of fear or because they're not being referred in some situations, or that there's decisions made clinically sometimes not to admit people because there's concerns that we need to have the capacity available. So we're having the conversation now with Clinical Council about how we get the balancing of the healthcare system to ensure that we aren't compromising care to people who would benefit from it, who are non-COVID. The other issue is that with the issues around the capacity in the system, we stopped all elective surgeries, and only were doing category 1s and urgent category 2s, and the government through the National Cabinet have decided that elective surgery should be reintroduced in both the public and private sector. And we're very conscious of the fact that we need to do that thoughtfully and carefully, and with agreement by our surgeons and anaesthetists about how we do that safely for them and safely for the patients. So that's being worked through at the moment, and a major component of that, of course, is making sure that we have the personal protective equipment available. And given that that's been a challenge for us, I think, up until now with the supply side, ensuring that we're confident we're getting the supply of PPE and that we can confidently introduce elective surgery in a way that keeps everyone safe. So they're the sorts of things we've been looking at on the service side of things, but I think it's there's lots more that we'll need to think about, particularly with the changes, and there's been a huge amount of really innovative things that people have done to provide care using technology and changing the models of care. Part of it, I think, we need to assess is what out of those models of care do we think are appropriate to keep, where we can demonstrate that the outcomes for our patients are at least equivalent as to what they were previously. And I think this whole concept of evaluating some of the changes that have occurred and thinking about what do we want a health system for the future to look like post-COVID will be a really important discussion to have not too far down the track.
Yeah, it's a great opportunity to get some of those more innovative models of care sort of out there and talked about. I 100% agree with that. Can I just go slightly sideways? One of the big issues that the GPs have been facing is not just about how do we bring patients back in for routine care and preventive care, but it's about rolling out the flu vaccination clinics. And I'm very mindful that there's been a lot of chatter amongst GPs about the difficulties that they've had in getting their flu vaccines there, and that there is now going to be probably a difficulty in accessing both flu vaccine and Pneumovax for the next, well, maybe 4 weeks. Kerry, would that be fair enough to say?
We're still pushing out the second dose, reorder for GPs, but I think then there's a period till June where there will be resupply. So we're very conscious that we will be not pushing it that hard in this period. And also I believe that the private market supply is actually quite tight and mal-distributed as well. Sometimes pharmacies have got the supply, sometimes they don't. So it's quite a challenging supply environment. And I think that reflects the community's response to flu. They heard the messages early that flu vaccination is a good thing to have, particularly at a time when you've got dealing with another respiratory virus of the severity of COVID. And it's pleasing to see that response because we really haven't had to do much publicity to get that response, and it's all credit to the GPs in organising yourself so quickly. We've never had such vaccine rollout at such an uptake at such an early time, and even looking at some of the data on the AIR, it shows our uptake is much greater than any previous year.
Yeah, I mean, certainly that's what we've been seeing sort of on the ground level as well with GPs, and I'd certainly like to at this point acknowledge the amazing job that GP clinics have done in setting themselves up to be incredibly innovative and resourceful in rolling out safe and effective sort of as many numbers as they have been able to do in terms of numbers. So I think it is good just to let everybody know that we're appreciative of that, but that there will be a shortage going forward, but we hopefully will have some more supplies in June, which will probably be well and truly ready to be rolled out, given that that's probably just as if flu does come along, that's when it's going to be. Just again, another sideways one before I let Penny jump in with some of the questions is about the COVID app, which has been rolled out over the weekend by the federal government. One of the questions that was put to me, and Penny was in the same meeting, was if the COVID app is well taken up by the population of Australia, as has been asked for by our Prime Minister and the Health Minister, what difference do you think that's going to make to the New South Wales health response in terms of lessening sort of the requirements on business and sort of workflows and social distancing?
So our capacity to loosen some of those restrictions ultimately depends on people's compliance with the behavioural things we want them to do, which is stay home even if you've got a mildest of illness, the measures around social distancing and frequent hand hygiene and seeking out COVID testing. All of those strategies will be really critical, and then having high rates of access to the testing, which will allow us to do that contact tracing throughout. We have to learn how to use the app in contact tracing, and so we're going to be evaluating the app and find out how it adds utility. So just to run through it with your GPs, it is programmed, if you've got it downloaded on your phone, which I did last night, and then I become infected with COVID, and then I get a call from the public health unit saying you've got a diagnosis of COVID, and then they ask me, have I got the app? And I say yes, and then they'll say, can I access your data online? And they'll send me a secure code, and I will allow them and authorise that Bluetooth data. The public health authorities will have those lists, and therefore I can generate, depending on when I have symptoms, to go back the 24 hours before symptom onset, or 48 hours if I happen to be a healthcare practitioner or an aged care worker working in a vulnerable setting. They'll then pull that list down. They'll have to interview me, and they'll have to then match up what they see in the Bluetooth data with the phone numbers recorded against what I'm telling them. And I think the lesson, you know, the sorts of evaluation things we'll need to understand is how many additional people this identifies than the traditional contact tracing. Does it make it quicker? And I think that there's other innovations we can use in terms of even now requesting that almost people self-populate a contact tracing form now. It's amazing when we ring very organised people, they've already thought about everyone and got their line listing of numbers, which obviously, and minute blow-by-blows descriptions of what they've done in that period. And obviously that will really facilitate our contact tracing. So I still think there's a lot to learn, but the better we can do contact tracing, and if we can keep contact tracing even in the presence of high numbers of cases, the modelling suggests that it actually has a significant impact in moderating onward transmission. So it reduces the effective R0 of the virus.
Thanks. Penny, I'll let you have a bit of airtime.
That's okay. Can I follow on from that and ask if there's any plans, there's a question here, to do sentinel testing of asymptomatic public in clusters? Because with this sort of relax of guidelines, there's been sort of a sense that we might have to relax for a bit and then pull back again, sort of have this sort of to and forth sort of stop-start approach. Is that likely to happen? Have some more asymptomatic testing in a deliberate manner?
Yes, it is being considered, largely in relation to outbreaks at the moment, but clearly we're keeping options open as we develop our intelligence and surveillance plans. But the way we're using asymptomatic testing is we are, particularly in the aged care setting, what we know is that aged care individuals often don't present with traditional fever. They may be poor historians. It may be very hard to elicit symptoms. And so when we go into aged care facilities, we are screening both symptomatic and asymptomatic staff, still doing the isolation for the 14 days, but to some extent it gives us quite an early indication of what we're dealing with in that aged care facility for those reasons. And so I think that asymptomatic screening will have a role, particularly in certain sensitive areas where we're really trying to establish who's positive. It may have a role in childcare centres or any other things where we know some of the population don't actually experience or present with symptoms in the way we would normally see things, and where we want to get more information about how transmission is occurring. So in summary, asymptomatic testing, we are certainly doing. Aged care facilities, I think we're very clear it has a key role in those. And we're learning that it may be useful in other settings, particularly in the context of outbreaks or cluster investigations.
Thanks, Kerry. And so then I guess leading on from that, I guess one of the questions I'm very keen to ask, and we were discussing it a little bit earlier on, is there's a bit of evidence that Charlotte and I have been looking at around the equivalence of nasal swabs or deep nasal swabs to nasopharyngeal swabs, even discussion of oropharyngeal. And I know that the guidelines for the CDNA suggest nasopharyngeal swabs, but there's been a lot of discussion around doing nasal swabs. And I know that one of the pathology labs is offering self-testing, and that video for patients on how to do it is a nasal swab, an oronasal swab. Do you have any comments on that, or any?
Look, I'm aware at a pathology teleconference that was held last week that they did, I joined that late, but they did present the fact that they'd done some control trials looking at the collection of those specimens in terms of observed collections versus trained testers. What would be useful, I suspect, is if I reach out to those private companies and get assimilate some of the evidence and maybe circulate it, so you can form your own views about in which patients those variety of different testing technologies might be useful. But certainly having variety, making testing easier, the fact that the pathology companies can drop it off at people's houses and get that self-collect, or drop off a bunch of them and have a broader self-collect. These are all important tools to have as we progress through it.
One of the other questions we were talking about earlier on was around sewage testing and whether that was going to become an opportunity or a way of surveillance. Would you be able to comment on that, Kerry?
So look, this has been raised with us, and so researchers at the University of Queensland and the CSIRO have completed a proof of concept study to identify SARS-CoV in untreated wastewater sewage using samples from 2 wastewater treatment plants in southeast Queensland. And then there's a research collaboration on sewage surveillance. It's called Colossus. COLOSSOS project has been set up to build capacity to deliver a national program, And this is a collaboration led by Water Research Australia and its industry partners, including New South Wales Health, Sydney Water, and a number of water utilities, health departments in South Australia and Victoria, research partners. It commenced in March 2020 and it's expected to take 15 months to complete, and there's 4 components to it. But just on the caution, there's currently no agreed method for the virus analysis in the sewage for COVID-19. They're developing methods, they're working across the nation. It's still going to be a bit of time, and there's obviously some challenges with the methodology. So I think we very much want to embrace all new technologies, but I think the message is this is a little way off before we'll know how best to use it to assist us in our response. But active work is being done by everyone you'd like to be working together for.
Charlotte, did you want to ask a question?
Yeah, I was just going to say, can I move into the school thing? As we know that New South Wales has been very good at letting everybody know that they're going to sort of do a bit mixed model of return to school with 1 day a week for most children starting in the 2nd week of May. I've got a few questions online with concerns from some of the doctors about, is there enough evidence? I know that what you'll have for that one, Kerry, because I have seen the evidence, but if you could just maybe talk about the evidence about children. And then the second one was about children who are in families with significant immunosuppression or elderly people, about whether there should be any difference in the way they respond.
So the evidence has got to be pulled together from a variety of different sources. So the work that Christine McCartney in the National Centre, which was published, and I think we can send the web link around to your listeners, was where in New South Wales we got the National Centre to assist us in doing more active case finding through nasopharyngeal swabs and also some serological studies to accompany the normal public health contact tracing, where we either had staff or children identified at a school. So the staff or the children attended school whilst they were infectious, and what we were looking at is who they then infected. And pleasingly, that showed low levels of on-with transmission. It also showed that the children, unlike what they do with flu and other respiratory viruses, were not super spreaders. They did not seem to amplify it. Christine McCartney indicated, if you have a child with flu that's been in the classroom, you'd expect many more cases of flu in that classroom. Even up to 20% of the kids in that classroom to come down with flu, which is a very different picture to what we saw with COVID-19. That's consistent with work done in the Netherlands as well. It's been consistent with the fact that children are underrepresented in our data in terms of the number of cases, and it's consistent with a worldwide picture that children just seem to be less severe disease and less infected. And, Christine McCartney's an infectious disease paediatrician, and she'll go, look, there's some hypotheses, but no one really knows. But, she's struck by the difference that this illness has compared with things like influenza, RSV, and other conditions. So on the basis of that and the fact that we know that schools are important for children's development, learning, and that the risk profile is low, with risk mitigation strategies, the Australian Health Protection Principal Committee, which is the chief health officers and a range of other experts, has had the position that children should be going and attending school. And we will continue to update that evidence and collect more cases and understand further transmission. We're very keen on generating evidence, and many countries across the world can't generate this sort of evidence, because once you get significant community transmission, any cases become confounded because you don't know how the people are actually getting it. You can't explore it because they may have had extraneous transmission. But in a low community transmission environment, you can then tease out what transmission is occurring in the schools. There's been a range of measures put in place in the schools, like social distancing for the teachers away from the students, staggering lunch hours, kiss and drop, ways of preventing the mingling, because what we're concerned about is the parent interaction with the teachers, and minimising those opportunities or the clustering of the parents together, which again provides greater mixing. So the schools have really been asked to do a lot of reconfiguration, and the idea of the staged progress coming back is really to allow each of the schools to learn how to put in place all of those new measures and implement them. Now, there may well be cases in children, and there may well be cases in teachers, but all we can say is the processes have been put in place, and we do not think that children are the contributors to that onward. You know, they're not behaving like they do for influenza as in major contribution to onward spread.
Terry, there's actually an interesting comment from one of the GPs down here saying if kids don't need to follow social distancing at school or aren't spreaders, why are they unable to attend soccer and basketball training?
Well, those issues have to be worked through, but some of the problems associated with all of those events is the attendant parents and other people. So as we know, children's sports matches are often just as much about the parents' interactions on the sidelines. So it may be as we open and learn more about what an environment is in COVID-free environment, we may then have to think about how we configure community sport or sports. Also, one of the things we've been concerned about is we haven't want to mix people. So a lot of the community sports involves bringing teams from all different areas. And that's been, I suppose, a concern. You don't want to have too much, you want to minimise the movements of groups. And so, for instance, if you had kids going from, the city into Bowral or something, that's a significant movement where you might potentially introduce it. So these are all factors that work at a sort of macro level where they're just different considerations for school sport. So initially the school sport was have it amongst your own kids in their own school, or maybe an adjacent school, but not minimised. But, we will have to start considering as we go through this COVID response how we tailor and calibrate to get this sort of, I suppose, normalcy back. It will never be normal. As the Premier said, social distancing and some of the strategies will be with us. But the question is, which things can we moderate and still get good control and suppression of the virus?
Yeah, I mean, I think that it's one of those evolving pictures, isn't it? So we do have to accept that there are some things that we will just have to roll out as it comes on. I mean, there's quite a lot of obvious sort of questions around what it looks like and who gets tested and that sort of thing. But I think we just have to go with the flow that the children are low risk within the school environment, and then roll out when sport, etc., can be added into the mix.
But it's a good point you make, Charlotte, there about, we're also saying any children just test, sniffles, just test, teachers test, early childhood workers, because there's also been some work in early childhood, and that again showed in the majority of the childcare centres there wasn't transmission, but in one which has been in the media, there was significant transmission, not necessarily led by the children, but again the adults. And so one of the key messages, and I suppose it's also a salient lesson for the doctors as well, is often in workplaces it's about the tea room. It's not about the structured environments in which people work. It's often around the tea rooms. It's around who's sharing cars when they're going home. So it's often about those sort of semi-social interactions in the day or at the end of the day or the beginning of the day where the 1.5 metre rule breaks down in those social settings where we see transmission occurring. And for early childhood, we're also conscious that parents often have a lot more, even more interaction than primary schools. So they've often got the child and engaging with the early childhood teacher or worker to find out how their child did in a more consistent way. And obviously that can also introduce disease into those childcare centres. So there's still a lot for us to learn about how do we mitigate the risk, but I think some of this information has allowed us to go harder on some measures consistent with the evidence.
So just around that return to school, there's a couple of sort of good questions, I think, in terms of what need to be the rules around the social distancing at playtime, lunchtime versus in the classroom. And then secondly, what is the way to get them to school? So is public transport going to be okay, particularly for those who would normally use public transport?
Again, the first thing is we are wanting to message if your child has if anyone has any symptoms, teachers or children, school is not the place for them. Err on the side of caution, bring the GP, get a consult, get them tested. So
and testing on minimal stuff. Can I clarify on that?
There's
a number of questions about the criterion. Anything, just test anything now.
Anything, scratchy, itchy throat, bit of runny nose. Let's just err on the side of caution, because in the end, it's in everyone's best interest for children to be engaged in schools and learning. And so we actually are asking GPs to take a very low threshold for testing, because that gives parents an assurance, and it means that it really reduces the time that any child could have been at school with any symptoms. And we know that children, if they have got COVID, will tend to have very mild symptoms. Not many. I think we had about 52 children diagnosed, I think under the age between 5 and 17 years of age. And basically there was one hospitalised for actually probably the COVID. One was isolated primarily because early on we were isolating people as an approach for when we were hospitalising them. And then one had another intercurrent illness and had COVID. So I think that sort of gives the perspective of the relatively small numbers in that age group.
Kerry, can I just get you to really clearly spell out? We keep getting a lot of questions around who to test, and children and adults. And you know, my understanding is, as you're saying, we test anyone we have any concerns about, whether they have fever or whether they have symptoms, even if the fever's below 38. Can you really clearly spell that out for all of us?
Oh yes. So basically, this disease can be so mild. Itchy, scratchy throat, bit of a runny nose. Anything, you know, at the moment, the real approach is test anything that has any symptoms. Sorry, I mean that in the nicest possible way. Yeah. Any person, child, and so have a very low threshold. The healthcare worker at the aged care facility that had the outbreak only had an itchy or scratchy throat. I can't remember which one it was, but it was one of those. And they were actually having symptom testing at the aged care facility. They were actually checking them and doing that monitoring. And so I think that it's very hard with the images of COVID associated with people on ventilators, and with the severe end of the spectrum being the profile. We probably haven't talked enough about how some people have so minimal symptoms. I remember a case, and I won't disclose the area, but this person was had returned from Italy, and elderly gentleman, you know, in his 80s. So again, goes against the, you know, the process. 80-year-old, but had been skiing, so obviously very fit, returned home and only and had a runny nose for 2 days, and then totally resolved the symptoms. And it was only because of a daughter, which he described as a nagging daughter, that made him get tested, and he turned out to have COVID. So I think we hear about all of the stories about the spectrum, and it just does lend me to the fact that tests have a very, very low threshold for testing. And that's particularly important now as we've got the capacity in our testing system. And just to reassure you, in general, the testing the turnaround times are much improved. I hope that's been your experience, but that's what the labs have been telling me, that they've, the real challenge is the logistics, particularly for your rural regional colleagues. It's really quick once they get to a hub where they're tested. But that's really the gap that we've got, is that rural regional logistics of getting the samples to the lab. Is that your experience?
Yeah. Yeah, no, absolutely. The other thing that follows on from that, I agree the turnaround times be much quicker, but the other thing that follows on from that too is that I know, again, the idea of the fact that once you've been tested, you don't then need to not be tested again. So I think it's really important for GPs to re-emphasise the fact that if you've had a cold, you've recovered, and you get another cold, you need to be rechecked or retested or stay away.
And minor symptoms. Can I also just go back to I don't think that we were clear in the answer about the social distancing at school in playtimes, and also the use of public transport.
So children are able to use public transport. They shouldn't go on the public transport if they've got any symptoms whatsoever, and that's important. That's incredibly important. But they can catch public transport to go to school. If parents are dropping them off, we're advising that parents don't mingle with other parents or interact with the teachers. They need to talk to teachers, do it on the phone, or at least 1.5 metres away. Schools, people will have to check how children are getting picked up, because that's probably an area where there'll have to be some sort of staggering or some sort of mechanism to do that. Then in terms of the social distancing, the children don't need to social distance in the classrooms, notwithstanding the schools are going to try and distance the kids as much as they can, and also have social distancing for the teacher. They're also going to be staggering recesses, so there's a smaller number of children playing around, playing outside. They've not necessarily allowing the kids to play on the play equipment because there is often more clustering or close contact there. But the children are able to run around, but there'll be less of them, and their physical interactions will be less.
Can I then, my final one on the school ones is the use of face masks. There's been a question about teachers and children using face masks. Now, my understanding is that I would have thought that a face mask gives a false sense of reassurance, and B, particularly with children, would not be a good idea unless they had symptoms. And if they've got symptoms, we don't want them going to school. So that, in fact, that sort of turns around that where masks in our current scenario are not in the least bit helpful, and may be a problem particularly with children, fiddling with them, being poorly fitting, and really not doing a useful job.
Yeah, look, I think children's ability to comply with masks would be very poor, and I think you're right, Charlotte, in terms of reintroducing as they fiddle, play with them, it would be quite challenging. I think the key message is don't send children even with minimal symptoms, and I think we're going to have to accept, the teachers are going to be very vigilant, and any parent that sends a child to school is going to have to accept that they're going to have to pick up that child. There will be face masks available in the whatever room or infirmary they've got, and the instructions are to put the face mask on any sick children should sick children get to school, and have a very low threshold for excluding anyone, and again getting them tested.
Can I ask Nigel a question? Nigel, we were talking earlier about the sort of the growing burden, I guess, of chronic care in the community, the cases that haven't presented, and you were mentioning how there's statistics showing that there's less presentations of both acute and chronic presentations. Can you talk a little bit about what the plan is to encourage those people to come into care?
So I might start off with children, because what's been most striking on the data that we've seen is the reduction. We've had a look at it by age group, and we've seen a massive reduction in the number of children from birth right through to school age that have not been presented to emergency departments or to hospitals or community health centres, and that's a reflection on what the decisions their parents are making about what care they should access. So we're really concerned about that, because, I mean, in part it might be because we've seen reductions in viral illnesses across the board as a result of good hand hygiene and social distancing. We've seen viral ERTs reduced. We've seen the presentations for respiratory symptoms reduce in our emergency departments. A whole range of viral illnesses are right down. So that might be one component of it, but we're also really concerned that it might be a fear factor about taking children to a service and then having them exposed. So that's a really important message for all of you when you're thinking about the parents that you're seeing and children accessing care. Really encourage them not take their children to access clinical care. If they've got anything of concern, they should be going. But we are very conscious. We're talking to the clinical communities of practice around what are the things that they believe have stopped that we probably should move to reintroduce quite quickly. And at one stage, as Kerry knows, there was even a move to stop some of the screening programs, some of the population health measures, which we have moved to make sure that we don't cease and that we keep those going. We want to have people who have positive fecal alcohol blood testing available to get their scopes in the clinical timeframes. We're very keen for people who are needing diabetes care to be continuing to access care for monitoring of because their outcomes will be much poorer if their diabetes is not well managed. And so there's a whole range of things we're saying to our clinical communities of practice. What do you advise us that we should make sure we reintroduce, and where you've seen changes in the patterns of care that are provided? And I'd urge the same for GPs. If you've seen things that have stopped that you think shouldn't have stopped, we'd be very happy to hear about that and to work out ways that we can start to reintroduce that care. Having said that, I mean, there's some things that have shifted quite quickly into different models of care where it may be a good thing to keep those going. So equally, where you've seen things that you think are a really positive change, how do we ensure that we keep those going? And I know, for instance, the telehealth item numbers have been amazing in making such a difference in GPs being able to provide care remotely, but also being remunerated for things that they were doing anyway, and now can appropriately bill for. So, if there's any opportunity out of all of those things of providing us advice about what we should be advocating for through our interactions with the Commonwealth and through discussions at RMAC. There's another RMAC meeting tomorrow. They're occurring basically weekly at the moment through these challenging times. There's quite a lot of.
What about breast screen?
Mate.
There's a sideways in there.
Breast screen?
Breast screen, yeah, because that closed down a couple of weekends ago, and I'm certainly be very interested to know when that's going to open back up again, given all of this.
Yeah,
Kerry, have you got an update on that? Because we're saying breast screen should recommence.
I think it's recommencing, Charlotte, but I'll get advice from David Currow on how that's going. But I think they recommence once the numbers had come down. So I'll let you know how that's going.
Yeah, well, certainly as GPs, we'd love it to be reopened because it's not a service that I think is, it's a bit like because the fecal alcohol bloods were have continued throughout, and there's been the conversations also about colposcopy clinics and access to those. So it'd be good to make sure that those are properly accessed again as well.
Yeah.
Okay, we'll follow up.
Even things like antenatal care and slowly bringing that back in, seeing a few people that are quite distressed by the changes there. One of the things I've heard is that there's been quite a significant reduction in pathology testing as well, which for chronic conditions may be an issue. I know I get involved in disaster research, and I know that 3 months and 6 months following a natural disaster, for example, there's a number of studies that show that the hemoglobin A1C is increased. hyperlipidemia is increased because people aren't attending to those usual things, and then you have increase in cardiovascular disease and things like that. So I think getting all of those things back into routine and having people starting to think about those again is really important, because otherwise we may start to see even more issues.
Yep, it's sort of one of those things about the as you say, Nigel, the telehealth thing has been fantastic. We certainly don't want it to be as much of care as it looked like we were going to have to do when it first got rolled out. But there's nothing like a bit of disruption and immersion to get something happening. So the goal now is, how do we use telehealth to the best of its advantage and ensure that we improve access to a large number of patients who I'm sure would really benefit, particularly those who find travelling to and from appointments difficult, where we know that often the appointment that they're doing is just a verbal type of follow-up of results and discussion about what's going on and doesn't involve the need for a physical examination.
Yeah, I think there are real opportunities to try and get that balance right. It's going to be important, I think, to capture some data around that, and also ensure that we can because I bet the Commonwealth would be concerned about retaining the telehealth item numbers after it's over, and we move back to more normal care as well, about what that means to the total outlay. So I think trying to ensure that we can demonstrate the benefits it delivers in terms of care for patients and what it means for GPs in practice, about how it's made improvements in what can be done to maximise the ability of GPs to be working at the top of their scope of practice. I think all of those things are really important to demonstrate.
And Nigel, there might be an opportunity out of the research funding to prioritise some of that primary care research and building the evidence for that sustained change. So maybe that's something we should follow up on.
Yeah, I think that would be good.
I think that's really important. I was actually going to say something about research, and I know Charlotte and I are quite passionate about this, but I think the problem is always that it's not documented what's happening in primary care, and so we can't justify our worth unless we have figures and stats and we can prove it. I must say I'm really excited about the idea of the telehealth and some of these other measures like the self-testing and the way they're rolling out this time, because I sort of, when you look ahead to the next pandemic, not that we want to get that far, but I just think how quickly we could now roll out some of these things without having to go all through this process to get there. So, yeah, I think it's an interesting space to be in.
We always
pain on Kerry's face then, Penny, when you talked about the next one. I think
well, I think it's really important to know that we are just at the beginning, and I think this is probably I know known to all of the GPs on this teleconference webinar that we are just at the beginning, but we haven't had that many infections. We haven't, to our best of our knowledge, got, widespread community transmission. We've still got, in my estimation, some community transmission, which we need to keep very suppressed. But if we looked at the prevalence of antibodies in the community, which we're now doing a sero survey, our best guess is it's going to be, 0% to 0.5. It's not going to be very high. And you've seen some of the estimates even from the US. New York City probably has the highest seroprevalence reported, around 20%, the city. But then as you go out from the centre, it drops down very much lower, and lower prevalences in places like California and other things. So America is still not through the worst of it. There still may be new additional waves. This disease is going to be with us for a long time, and I think that's why we're also particularly passionate about schools, because this is not going to be about 3 months. It's not going to be about 6 months. Increasingly, it's about 12 months and, longer. I say that and my colleagues cringe, but the reality is until we actually have an effective treatment or a vaccine, it's hard to see absolutely how we will navigate the path through this.
Yeah, well, that's
but on a positive note, we have a great healthcare system, and we're doing well, and we have great GPs, and we have great hospitals and a great coordinated health system and a good, you know, something to be very proud of. So we can get there, but I just wanted to make sure that everyone realises that the journey ahead is a long one.
Well, certainly what we have an opportunity to do is make sure that all the things that we realised were lacking right at the beginning when it looked like it was going to surge off, which is around making sure that there's adequate PPE in all the places that we need it to be, that we have good protocols of care, particularly for our aged care facilities. I mean, there was a question which we sort of haven't addressed, which is when are the aged care facility access is going to be opened up so that they can have visitors again. And that sort of again goes to the sort of that whole, how rigid do our guidelines need to be to make sure that people keep safe, but at the same time, can we make sure we have all of those protocols in place and the equipment so that if it does surge up again, that we're actually in a really good position to respond well?
So I think the issue there is that the current recommendations are not for no visitors, not for a lockdown of facilities. It's very much, sorry, my dog's just, we recommend a limitation of visitors, right, by the Australian Health Protection Principle Committee, not to have lockdown for no visitors. But having said that, I just want to note that the the aged care facilities that have done that from the right place. You know, they're trying to keep their residents safe. I think what we've started to do is open up a conversation, and it's quite a difficult one. It's around how much do we protect the residents, but what about quality of life versus risk? We can see that if COVID-19 gets into these facilities, it can have devastating consequences. And so how as a group do we decide where those settings are positioned? This is people's residences and homes, but it is a collective residence and home. These are complex decisions that, you know, I think you have a key role in us shaping, because we have to have that conversation. And I also acknowledge that GPs are really important providers for healthcare into these aged care facilities. So obviously limiting the number of people into the aged care facilities reduces risk, but is it worth it for some of the attendant other benefits? And that's some of the debate. But just to be clear, the current settings that the Australian Health Protection Principle Committee says is about limiting visitors, not letting necessarily children and a broad number, minimising it rather than the total lockdown. But noting that you might lock down facilities if you had quite rampant community transmission in areas. So lockdown might be appropriate in those settings. But this is a really difficult discussion with aged care providers and residents of aged care facilities, their loved ones, and GPs play a part in having that debate. And it's probably something we need to continue to discuss.
Penny, and there's a question that's come through about why will there still be cases in a month's time? And I think it's maybe good that we have that question out, because I know that that's one that why will we if we successfully eliminate it? And going on to then what does that actually mean in terms of Australia and New Zealand going into the future?
I think there's a real question about, can we eliminate it? And it will take us a very, very long time to ever know that we've eliminated it. And some of the characteristics of the virus that make it really tricky to eliminate is its mild nature. So that requires everyone to adopt health-seeking behaviour, everyone to get tested and to not miss any cases. Also, we know that there is some asymptomatic carriage.
Kerry, doesn't it also require live under these arrangements for a long time to eliminate it?
That's correct, Nigel. It requires us to live under these arrangements for a long time, with the corollary impacts on health, impacts on mental health, impacts on well-being, impacts on, you know, people's willingness to prevent for chest pain or people's willingness to prevent for stroke. So there are a number of challenges with us eliminating, notwithstanding. There's also some definitional issues around what we mean by elimination. I think Jacinta Ardern has used the elimination phrase, but has qualified it to mean probably low levels of transmission where you jump on them really quickly and have zero tolerance for any cases, as that sort of definitional issue of what she's seeing elimination. So I think we will do our best to suppress the disease to the lowest level, but it is a balancing act. And in the end, that is not the end game either, because across the world, the virus will still exist. Whenever we open our borders, if we haven't got the 14-day quarantine period or isolation settings, it can still be reintroduced. And until we have a successful vaccine or an effective treatment, or we get that level of immunity in the population, we are still vulnerable to quite rapid upswings in cases if we lose control. So the elimination, suppression to very low levels is a sort of, it's an argument about whether they probably are the same thing, because we would have to, as Nigel said, we'd have to go hard and very long to ever know that you got elimination.
Can I get that very long?
Sorry?
So how long is very long? Just so people get, if you are going to say that you are going to go for the elimination, how long is very long? And then given that we aren't going down that track, when is it likely that things like the state borders can at least open up?
Well, I don't think that the government sort of, I suppose, pronounced that we're going down the continued, suppression to very, very low levels, with elimination as maybe something that is a consequence that we hear about. But it's probably considered on balance more likely that we will continue to suppress the virus at lower levels. I don't think we've totally ruled out that some areas can eliminate, or that's our course, but I suppose there's a lot of reasons why that is concern that we won't achieve, that won't be an achievable outcome. But we are still at the moment grappling between those two scenarios. We've certainly given away any sense of controlled transmission, which is the Swedish model. So the model we're probably pursuing is more along the Taiwan model, that very, very low levels of cases, or the similar to New Zealand.
And WA has had no cases for a few days, so we don't know if they have eliminated or not, but they have already relaxed to groups of, I think 10 they're allowed to have socially meeting together. Queensland has relaxed stuff, but they do actually still have ongoing cases. So obviously there is differences in how each state is going to approach. That's obviously going to be the ongoing thing as well, isn't it, Kerry?
And it's going to be a timing factor. Queensland and Victoria at this stage are not having schools going back. And so, again, one of the things that we sometimes want to do is do a few interventions slowly, and then see how that what impact that has. We also know economically that, and this is not driving at all the behaviour, that economically that children going to schools is good for the economy as well. And also we know that it also, because it increases parent productivity. So if you put an economic lens on it, schools are important. That's not at all why health has that view. It's totally independent of that. But it is an example where there's a strong alignment between those things that can increase productivity, as well as where it is considered on balance good for the health and well-being of the children.
So I just want to thank you, but I want to say that Bethany, time's sort of running out, and I think Bethany was going to ask the last couple of questions and then wind us up.
Perfect. Yeah, so just in regards or going back to the school children, we've had a few questions about those children from high-risk families. Are they still okay?
So look, I would, I'm sorry, I'm going to answer this in a way that puts more pressure on GPs, but I think that, and I've received some correspondence as well from people with complex families, you know, people that are parents that are quite elderly, parents that might be having cancer therapy. And I think basically education is going to be quite flexible in the approach. This is really about a risk management. We could lay out the evidence for what's going on in terms of community transmission. We'll be open and transparent about any transmission in schools. And I suppose you just need to make those decisions about the advice you'd give to those children and whether there's any circumstances where you think that risk was too high. We're also doing a separate piece on boarding schools and providing advice on the framework for boarding schools. And obviously boarding schools are at even greater risk because of the way of transmission. Not necessarily the children are not any greater risk than the other children, but they're at greater risk of having transmission because of the closed environment. And boarding schools will need, schools with boarding schools will need to have a lot of system, you know, outbreak plans, as more stringent management plans, and also like a decanting of the boarding schools so that we really minimise the numbers and make sure that we can really keep those safe. But again, for rural remote children, it's may well be in their best interest to come down to boarding schools, and we need to work with schools to create those safe environments and safe spaces.
Perfect. Thank you so much for that. Now it does bring us a little over 8 o'clock, so unfortunately that is all we have time for tonight. I just want to say thank you to our panel. You've been absolutely amazing. We do really appreciate it. And thank you to everyone online for attending tonight. Unfortunately, we can't answer all the questions. It is such a short time period, but we do work behind the scenes to get those answers to you. So thank you again.
Thank you.
Thank you. Thanks, everyone. Good night.
See you later.
Bye.